Good morning everyone. I am Dr. Vijeta and today we are continuing our discussion on recombinant gonadotropin. Let's discuss polytropin delta. So polytropin delta is the most recent recombinant FSH and it was developed in 2016. So this is regarding the history and it was the brand name which was used is Recovel. This is the Recovel. And the origin, the cell line which is used to make polytropin delta is the human fetal retinal origin cell lines. So one question I wanted to ask you all is what is the cell line used in polytropin alpha and polytropin beta? Please answer in the comment box. So the amino acid which is in the alpha and beta subunit of polytropin delta are identical to that of the human or human FSH, natural human FSH. But there is sialic acid content. The main difference is the sialic acid content which is higher in polytropin delta. That's why it has a longer elimination half-life and also a higher ovarian reserve was achieved by using the polytropin delta. This is about polytropin delta. Let's discuss one study related to polytropin delta. So the trial is individualized versus conventional ovarian stimulation for IVF and which is popularly known as Ester 1. So let's discuss it in detail. Let's discuss this trial which is about the polytropin delta. So in this they have compared what? They have compared the efficacy and safety of polytropin delta and the dosing was based individualized. That is, it is based on the AMH value and the patient age, body weight, according to the AMH and body weight, as compared to the conventional dosing which is done based on the patient response ultrasound feature of polytropin alpha. That is, they have compared polytropin alpha conventional dosing and individualized dosing polytropin delta, and they have seen if we do the individualized dosing with polytropin delta, the ongoing pregnancy rate is similar, the live birth rate are similar. Thus if we do the individualized dosing based on AMH body weight, then we will be able to it will be able to improve the safety compared to the conventional dose and the efficacy will be similar. That is, the pregnancy rate and the live birth rate is similar, but the risk, that is the chances of OHS, will be less if we do the individualized dosing with polytropin delta. After polytropin delta, let's discuss polytropin alpha. So the polytropin alpha has an extended half-life and duration of action. Why it has extended half-life and long duration of action? The reason is in the structure. So as we know, the alpha chain and there is beta peptide chain and there is then glycosyl group attached to it, alpha and beta subunit. So the alpha subunit is of the recombinant similar to the recombinant human FSH, but the beta chain is a hybrid beta chain. It contains the beta subunit of human FSH, but also the C terminal of the beta subunit of HCG. That's why it has a long half-life, because the HCG molecule have increased number of glycosylation. That is, the oligosaccharide group which is attached to the beta chain is more in the HCG. That's confer its stability. So if we attach this C-terminal chain of beta HCG, which has more number of glycosyl group than it provided stability, lead to the extended half-life of this molecule. So this has a half-life of about 65 hours. Let's discuss this graph regarding chorefolutropin and recombinant FSH. So the chorefolutropin is depicted in the blue line and the recombinant FSH in the green. The chorefolutropin, when we given on day 1, its action peaks, and then it remains till above the therapeutic level till day 8. As compared to this recombinant FSH, in which we have to daily give the injection so that we will achieve the therapeutic levels above the therapeutic level. So that's why we have to, and in this only we have to give injection and on day 1, and its effect remains above the therapeutic level till day 8, as this is because of the more prolonged action of chorefolutropin. Thus, we have to give the injection for 1 week. One injection will valid for 1 week. So, only one dose will replace the first 7 daily injection of recombinant gonadotropin. And this got now approved to use in ART cycles in Europe, and the first live birth from chorefolutropin was achieved in 2003. Let's discuss one Cochrane review regarding the long-acting FSS, that is chorefolutropin. So the result were, there is, if we give the lower dose of chorefolutropin, that is 160 to 120 microgram, then it will lead to a reduced live birth rate, as compared if we give a medium dose, that is 150 to 160, 150 to 180 microgram, it will lead to the similar live birth rate, that is live birth rate is similar. So this means the medium dose have similar efficacy, but the lower dose has low live birth rate. After discussing recombinant FSH, let us discuss recombinant LH. So, recombinant LH is lutotropin alpha or lutotropin and they come in preparation with folutropin alpha plus lutotropin alpha in the ratio 2:1, which is known as pargovirus in market. So, why LH supplementation was needed? They have noticed that the LH supplementation is helpful in population who have LH insufficiency, the hypo responder, which do not respond to the FSH. Then we can add LH component also in the form of either recombinant LH or either LH derived from the urine. So this is known as pargovirus, which is market name. After discussing the recombinant FSH and LH, let's now discuss the recombinant HCG. So, recombinant HCG is used for the final triggering of the ovulation. So, it is act as a final trigger. And the name is Ovidrel, and the 250 microgram recombinant HCG is as effective as 500 international unit of urinary HCG. So, what's the role of it? It will promote the granulosa cell luteinization, that is switching from the estradiol to the progesterone synthesis. The second is it initiate the resumption of meiosis and the oocyte maturation, and this will lead to finally ovulation, that is follicular rupture, which occur 36 to 40 hours after the HCG trigger. This is the picture showing the same thing. That is how beta HCG injection or HCG injection will lead to final stage of follicular or oocyte maturation. As you can see that at birth the primary oocyte is arrested in prophase 1. Then it will go meiosis 1 at the time of puberty. One by one follicle will go to meiosis 1 and it forms secondary oocyte and first polar body, and it got arrested in metaphase 2. So this maturation, although the final meiosis completion is after the sperm enter the ovum, this will lead to the completion of meiosis 2, formation of zygote and the second polar body. But the maturation, nuclear maturation, when it get arrested into the metaphase 2 of meiosis 2, it will occur by the HCG. So this 36 hours will be required for the maturation to occur, and then 4 hours approximately later will the ovulation will occur. So total is 40 hours. In the next class on gonadotropin, we'll discuss the manufacturers, what are the generic name of each product, and the manufacturer generic name, the prices, and other things in the next class on recombinant gonadotropin. So thank you everyone. I hope you like the lecture.